side of the paint's gonna be. That's where you forgot to take the ring off. Not all rings come off. I understand that. You do the best you can. Okay, we showed you this in class. For us, there's no AP, it's always PA. All right, child or adult, this set of x-rays.
Child.
Child, there's a growth plate, there's a growth plate, okay? Now that's important as we develop pathology because kids get certain types of injury when they do push. Okay, adults, this is at risk. What's this? Scaphoid, okay? And notice there's radiolucencies between the joints, so the intercarpal joints are symmetric. If you go, you get one concentric line when you do this. So the proximal, they should be, it's a nice smooth uninterrupted line. And if you go to the distal portion of that joint space, that should be concentric. And then if you go just the joint space anterior to that, you will get 3 concentric arcs. That's when you know there's normal alignment. Okay? Now notice, it doesn't show as well as I would like it. Generally the ulnar styloid process is a little bit shorter, half a centimeter shorter than the radius at the drudge joint. That's the normal relationship. So there's a normal. If it's dramatically shorter, that's called negative ulnar variance. And if it's dramatically anterior or distal to it, that's called positive ulnar variance. What does that mean? That means that you have disrupted the drudge ligamentous holding elements and you've got a floppy intercarpal joint. All right, so it's always based on normal. We said oblique views, I don't know, okay, this will work, this is ulnar deviation. Why do we do ulnar deviation?
So you can see the scaffold.
Yep, okay. We do radial deviation so we can see ulnar styloid process region. What's the TFC?
The
Triangular fiber.
So when you fall on your wrist, the push injury, you can disrupt and tear the TFC, and it doesn't manifest itself because you can't see it very well. So that if they continue to have ulnar pain on the ulnar side, we need an MRI because we can't see TFC on the hindfoot. Now,
T2,
the MRI will show the tear. The question is, how big is the tear? Are you predominantly, do you do something that require that lateral side of the wrist to be pain-free? So they make decisions on whether they have to do surgery or not. Small tears will fibrose, okay, and just
Heal on its own.
heal. Okay, so I went to the ophthalmologist yesterday because I had a floater. Okay, I've had floaters before, but this one is bigger and hasn't gone away. Okay, but I know that I don't want a retinal tear. Okay, so I just have to live with it. Just not everything needs surgical intervention. Okay, all right. So on the lateral view, if you bisect the radial styloid process, it should bisect the lunate, and that should articulate with the capitate. Okay, and that's normal anatomic relationship in the wrist. The positioning is easy. The evaluation of the wrist is a lot more difficult, so you need a little search pattern for the views of the wrist. We've talked about this, so that's a bigger ulnar styloid process, yes? Okay, we want to make sure we don't miss scaphoid fractures. So anatomic snuff box discomfort. When they say if 2 weeks late into it, I still have an ulnar anatomic snuff box pain, they're not going to say that. They're going to say it's right here. Okay, that means it's not getting any better. You don't want to miss scaphoid fracture, so you do ulnar deviation. They still have ulnar deviation pain and discomfort. You need an MRI so that you don't miss osteonecrosis. What's osteonecrosis?
Necrosis of the bone.
Bone density, the vascular
Bone density
supply
loss.
to the bone is disrupted and then the bone cells die. Okay? We sort of need our thumbs, we need our scaphoid. Okay? So unresponsive scaphoid or anatomic snuff box pain. Okay? So it's called the snuff box because back in the day it was the brown powder, now it's the white powder.
Cocaine.
Insane. Okay?
Wait, that was unresponsive scaphoid and what?
I don't remember what I said. Unresponsive snuff box discomfort. More than two weeks you can interact. If you think you have a scaphoid fracture, don't wait 2 weeks, get the MRI. If the MRI is normal, that's still a good outcome for you and your patient. If they find a subtle scaphoid fracture, they get on it. Because we don't want abnormal, we don't want to miss a scaphoid fracture, and we don't want the sequelae of missed scaphoid fracture, which ends up being advanced degenerative joint disease.
Right.
Okay. That's what it looks like on an MRI, okay? Just to, we'll develop that pattern. These are tendons, okay? So the detail is more intense. That's a scaphoid fracture. That's a density, a signal intensity, a dark signal intensity that shouldn't be there, all right? Now, why don't we do MRIs on everybody's wrists? Because it's just not, it's cost prohibitive, all right? Your plain films in the less between 20 and 40 years of age aren't going to show an awful lot unless they have trauma. But as we get older, okay, push injuries have significant impact on our
Scaphoid.
cohorts, right, our elderly patients. Okay, so nothing to be seen on the plain film. You took a nice plain film, all right, you looked at it, and she does a great job. If you like this approach, when you click here, it'll show you the jagged line that we missed, okay, and it'll colorize the abnormality. So this is out of the Netherlands, I think. I don't know how far I can't say she's done all the anatomic areas of the extremity of the appendicular skeleton, but what she's done well. If you like that, okay, it's worthwhile looking at. The other point is, this is how National Board Part 3 works, plain film, okay? And if we see something, bone marrow edema on the MRI, that will manifest itself in the question that's being asked. So the MRI shows more information because it is a more detailed examination, and the BME is nothing more than increased signal intensity because of inflammation post-trauma, okay? And the fact that you can order these things the day you graduate is a scary thought, right? So then we need to at least know when they say there's bone marrow edema in the proximal fold of the scaphoid, what does bone marrow edema look like? Oh yeah, not a problem, Dr. D talked about it, it's increased signal intensity. Okay. Now what should happen to the bone marrow edema if it's treated properly?
Goes away.
Should go away, reduce or go away, okay?
Where would you like to be? Okay.
Okay, and then we talked about hand x-rays, okay, so I showed you this, but this is what it looks like. Semi-supinated view, also called so Dr. Nordgaard, way back in the day, plain films, he found, or they found, that this presented the metacarpal heads best or better than the PA view, and that was for the detection of rheumatoid arthritis. They still use this, by the way. Okay, we're just saying there's another way to see that area more clearly to tell if there's rheumatoid arthritis. That's why it's done bilaterally and symmetrically, but also if you're worried about subtle trauma. Now, we said subtle trauma is best evaluated. The smaller the joint, the more views you have at it, okay? So I'd rather you do PA, oblique, and lateral view of the wrist. You're gonna find more things than if you do PA and just lateral, okay? So normal, that's pretty obvious when you compare side to side, okay? There's deformity. This is what the normal metacarpal head should look like. All right, so the idea on when we did hand x-rays, we want to do PA, oblique, lateral, and then the semi-supinated or Nordgaard view if the patient says it hurts here and you didn't see anything on your PA examination.
Is that the fifth metacarpal?
Yep. Okay, this. Or the 2x4 hits, because I'm supposed to be clever enough to put up my hand to avoid the strike.
So the oblique is better for your first metacarpal view,
No.
and the Nordgaard is better for the fifth?
No. This will show us second through fourth.
Oh, I see.
It's not
Because
one
of
or the other.
writing. Got it.
Yeah, because we're at head of third metacarpal. Okay. Okay, which wrist?
The left.
Colorado.
What'd you say?
Colorado.
Oh.
Okay, now why do we keep stressing that? That's how reports are done.
Good.
Okay, and when you get to semester 7, there's two buckets, the way I teach. There's the SI bucket and there's the adult bucket. Okay, in this SI bucket, we have certain disease processes that favor kids. Okay, in the adult bucket, I have something called metastatic disease, METS. All right? Now, can you have METS in a child? Yes. My argument is the parents know about that because the child's not getting, they're not thriving, they're agitated, they've been evaluated. If they find METS in the skeletal immature, they're probably being treated with an oncologist anyway.
Mhm.
So children can get metastatic disease because they have an abnormality in the kidney. That's not going to present to your office, I don't think. But in the elderly, whatever we deem elderly to be, there's this phenomenon called metastatic disease. So if I see this, I'm not looking for metastatic disease, I'm looking for disease processes that affect little people.
Mhm.
Does that make sense?
Yep.
Okay, and if you want to do little people, go to a site called Don't Forget the Bubbles. Okay, it's all about pediatric whatever. If you want an approach to the pediatric risk, that's where I would start. All right, so our search pattern, this is what?
Scaphoid. Lunate. Positron.
Okay, so what's this radiolucency?
Forget the name of it.
Well, that's the capitate, what's the radiolucency? So if
This
we
is
go
the,
back, all right, so if you graph this area, the radiolucency. This is the bone, this is the bone, this is the bone, this is the bone, what's between the bone?
Joint, joint space.
Scaphoid,
Lunate.
there's supposed to be a joint space between lunate and triquetral.
Okay.
Where's the joint space? The joint space is missing.
Diminished.
The joint space, there should be a joint space between, there's this joint space here, there should be a joint space between lunate and triquetrum, there isn't. Okay, this is called carpal coalition. Fusion or non-segmentation between lunate and triquetrum. So this patient was born with this. Okay? Now, you know me, what does this mean to you, the clinician to be?
It's a normal variant.
It's a normal variant, but should this particular individual be a chiropractor?
No. Would have pain.
Probably not, okay? But what if they're a left-hand dominant electrician? Is their proximal carpal row going to behave the same way as yours and mine?
No.
Okay? So first thing is what kind of view is it and the recognition of the abnormality. It's a normal variant because there should be a joint space between lunate and triquetrum. Okay, and it's also the most common site for hand
Fractures.
coalition.
Can't see that.
I know.
Oh.
I feel like the Miami Heat.
Oh, whatever.
Okay, COALITION, fusion. Fusion from birth. And my argument is, if they are left-hand dominant, they're going to develop possibly degenerative joint disease in the wrist, different than you and I who doesn't have that. Now, that's case dependent, so 5 years from now, 10 years from now, whatever you think is appropriate, you'll do a PA view of the hand and see if they develop degenerative changes. Then you need your friend, the hand surgeon, and say, what are we going to do about it?
Right.
Okay? They complain of hand pain. I've done conservative care. I can't do anything else. What do you suggest? Okay?
Mhm.
I think that's how the radiology game is played. Okay? Just to say, well, you've got carpal coalition, it doesn't matter. It depends on who has it. If this is a left-handed guitar player, would that make a difference? Thinking? Okay?
Mhm.
All right, so you can have carpal coalition. This is the most common site, I think, between, doesn't matter what the second most common is. Let's just worry about most commons. Okay? It's easy to pick up on MRI, just an example of it. Okay? And it has, as I said, complications.
Is that the T2 weighted?
Well, I think we had a little bit of everything. Okay, 1, 2, and fat suppressed. Okay, but what this shows nicely is what? What's this triangular thing?
Oh, that's a TFC.
That's TFC. Okay, and you can have tears in the TFC vertically or horizontally. So you just get a lot more information. Now this is the patient who's had pain on the ulnar side for the last 6 months. Nothing helps, they need an MRI. Can they do a ulnar deviation view in the MR scanner? Sure they can. Okay, they'll try and stress it.
So
Okay.
that looks like a fusion, but it's really not.
It is a fusion because it didn't separate at
Okay.
birth
Okay.
into 8 carpal bones.
Okay.
2 of them got stuck together.
So carpal coalition is a fusion.
Yes,
Okay.
congenital fusion.
Congenital fusion.
Okay.
Huh.
If I do surgery to it, I can fuse the bones, right? Then it's a surgical or acquired fusion. And those are just words, but you were born with this
You're born
abnormality.
with
Okay. Questions on wrist? Straightforward, right? Hand, central ray goes where?
The third metacarpal.
Third meta
Carpal.
carpal. Okay. All right. Anything else for me? The shortest wrist lecture I've ever given. Wrist and, yeah, not hand, but just wrist. Okay? The biggest problem is detection. Easy to do, but it's a little more complicated. Now you can say, well, I'm not going to be x-raying extremities. That's a choice you make after graduation. As long as you're here, you're gonna be treating and being asked about hands, wrists, ankles, and knees. Okay? Questions for me?
What's on the rest of this lecture?
I don't know
Not
what,
have to worry about it.
Oops, sorry.
I don't know which one you have. I go, keep going? No. So, on this one, okay, there's nothing except cases now, right, on the one that I
Oh,
have.
those are all cases.
Yeah, okay, so, this is what? Well, first of all, which shoulder, which examination?
Right
Right, what?
Right.
shoulder.
Shoulder, okay. Now, we see abnormality here, where is here?
Glenohumeral joint.
Proximal to the head of humerus, what lives there anatomically? Glenoid, labrum, good, what else?
Subacromial.
Subacromial bursa, this is subacromial bursitis, okay? Infiltration of calcium within that subacromial bursa. And it can actually have a communication with the deltoid,
And
can be
pinchers.
huge. But bursas don't move, right?
Nope.
They stay constant, so we talked about this the last time. Bursal calcification stays constant. When I do this, the calcification within the tendon will move with my movement of my tendon. So the big difference is, know the difference between tendinous calcification and bursal calcification. All right? Now, if you take this in, if they do a procedure, they'll suck the calcium out of the bursa. If the the aggravating activity doesn't get stopped, it'll come back. We'll go through the same process 6 to 8 weeks later. It's related to abnormal motions. Okay? Tendinous calcification, again, calcification where there shouldn't be calcification, most commonly in the rotator cuff is the shoulder. All right?
Is that an A to B shoulder?
Yes, internal rotation, both internal rotation. Okay? Now, the reason we do landscape is why? So that I can see the glenohumeral joint, the acromioclavicular joint,
And
sternoclavicular joint, and mid-thoracic, like in this case, put yourself
Manubrium.
a marker or something. This is all bony proliferative change or spur formation. Okay? And just me, I wouldn't manipulate, I would mobilize until I get a sense of, does that relieve your discomfort? If not, don't whack even harder at it. Okay? This is a spine that has degenerative changes in it, and at some point that joint that is undergoing fibrous ankylosis can become ossific. Okay?
And fused.
Which is fusion, yeah. Okay? The worst patient is someone who has had chronic back pain for, let's say, the last 5 years. They're never getting, I shouldn't say that. It's not likely that that patient will ever get back to 10 out of 10. But if you get them 8 out of 10 and they keep doing their part of it, their responsibility, the exercises, the stretching, whatever, yes, they can maintain that. But if that joint has been locked, quote unquote, for the last 5 years, it's not going to return to a normal
motion.
range of motion that someone who doesn't have the osteophytes or fusion around it. Okay?
Am I stupid or is that the wrong marker on there then?
No,
That's a PA view then.
pardon?
Is that a PA view then?
No, it's a right, okay? If it was a left, it should have showed a portion of the heart unless we missed it. So it's all good. No, there's no, this is the accepted position. Okay, if I turn this way, Robert, and put the right marker here, the X-ray is going through everything, right?
Yeah.
Maybe I'm not understanding where you're
I don't
confused.
know, I guess I'm just.
I think
Like,
I,
yeah.
I
thought
think
it was
I'm
the wrong
looking at
marker
this.
because it was a PA.
If I'm looking A to P, is that not the left shoulder?
Yes, so you're saying,
Yes.
okay.
That's how, I don't know.
No, you're absolutely right, okay, we're assuming this was done in AP position.
Yeah,
But if I don't know that, which marker's on here,
on there, right?
okay? So if you use the wrong marker and aren't following our accepted anatomic position, it could be messed up, okay? So when I first looked at it, which shoulder, right or left, because you see the marker, you said right. Now, if they didn't follow our protocol, okay, this could be mismarked. Now, how do I solve that problem?
Take another X-ray, because you have not.
Take another X-ray, I don't see the hard shadow, so I'm saying, there goes my left standard marker that I could use. If you didn't take the X-ray, you're gonna have to call the office and say, how was the patient positioned? Okay, so was their chest facing the X-ray tube, or was their chest this way? In other words, we've gotta find out what it is. Okay? Let's do this one first.
Agenesis of the posterior arch.
Okay, clinical implications.
To a P.
Cord is not protected, next step. Refer, but I want, why do you refer? Give me a clinical reason why you'd wanna refer.
Because it could be cord damage, it could be anything.
How do you know it's cord damage?
It's possible, I mean,
Right, so you want the
you don't know.
CT scan or the MRI,
MRI.
okay? The cord's not protected, I wanna rule out things like Arnold-Chiari, I wanna rule out all kinds of abnormality related to the soft tissue, in this case the cord, okay? If you Google this, should this patient do activities?
No.
Okay, and that's what you wanna have in your file. I have information here that says you shouldn't be a skydiver, and they say, come on, it can't be that bad. Yes, it can, because your spine doesn't have the protection. This is not empty space, this is fibrous tissue.
Mhm.
Okay, and then you'll run across an article. Patients with complete agenesis of the posterior neural arch have a worse prognosis in hyperflexion, hyperextension injuries. Is that useful for you?
Yes.
Yes. You don't have to spend days researching it, but you're just trying to find stuff that protects and supports your position. Does that make sense?
Yes.
Okay? Now, interestingly enough, when I was in court, I said, I have an article here that says, 10-year study in whatever it was, says that there's people who have pre-existing conditions actually have a worse prognosis than those that don't. And I just said, do you want to see the article? The attorney said, no, I don't. Why did he say that?
Because it made this proof.
It weakens
course.
his position.
Yeah.
We're arguing saying, if you have pre-existing degenerative joint disease, which we all do, and when we're over the age of 40, they're trying to get out of the payment because they say it's pre-existing. Yeah, but pre-existing means something. That means a longer treatment time, worse prognosis, recurrent symptoms, all those things that go along with it. That's why we're asking for this settlement, so that
That's
we can
why
help
they
the
need to be
patient
treated,
defray
yeah.
those costs, okay? They don't wanna see it because we're padding our side. They could have padded their side with saying, I've got 3 articles that say the exact opposite. So now it's a question of who convinces the jury the most. He said, no, I don't wanna see it, put it away. He knows exactly why he wants me to put it away, okay? So information is very, very useful in the appropriate clinical setting. If I have a clinical photograph of a person's, they have a big bruise because their sternum hit the steering wheel, does that help the case?
Of course.
Absolutely. Why? Because it shows the extent of the damage, okay? So the attorney says, I'll take the case in a heartbeat. The other attorney doesn't even want it because you have objective evidence that there is
Small
bruising.
chance.
And the bruise better go away. If it doesn't go away, that means it was severe enough that it's going to take more than just 4 to 6 weeks in the typical case,
Right.
all right? And after a while, it got to be a fun game. It's just a game, all right? It's nothing about your reputation. Don't take it personally, okay? They're just trying to paint you in a bad light. If you don't give them that ammunition, they're not going to be able to do that. But that means some work, okay? All right, this one?
Block vertebral body. C5 and 6.
Okay, complete or incomplete? Well, okay, you need flexion, okay, because I don't see a joint space between this and these spinous processes are approximated, all right? I just saw one this morning between 2 and 3, okay? C2 and 3 were sharing one spinous process of 2, All right, so you know what to do. Okay, this is not unusual either. That's, instead of this posterneural arch, it's just laterally flexed a little bit. Okay, a normal variant in terms of presentation. Now, if this was your patient, you'd be able to say whether there's abnormal. You are able to examine the patient. I can't. I'm just saying this is something I see. What it means to whoever sent me this, I have no idea. Okay, but it's not abnormal. It's in that normal variant range. All right. Oops. Okay, let's keep going. I know what it is because I took the picture. I'm trying to give you some kind of context. This is a large uterine fibroid. Where's the uterine fibroid?
In the uterus?
Where's the uterus then?
Pelvis.
Thank you.
Sorry.
And then we said the follow-up imaging for a small, medium, or large uterine fibroid is what?
Ultrasound.
Diagnostic ultrasound, okay? All right, this just happens to be a big one. I should have the full lumbar x-ray, but I didn't, okay? Body part?
The knee?
Okay, in the knee, how do these densities get inside the proximal tibia and the epicondylar region of the
Surgery.
surgery? What kind of surgery?
ACL.
ACL, reconstruction. Jerry, give me a 5-minute discussion on what can happen to reconstructions of the knee.
Briefly, they can be rejected by the host
Okay,
or the recipient, and you can have an autograft or an allograft. Autograph is going to be from yourself, and commonly they use the hamstring for that, the medial hamstring. And then for the, what's it called, cadavers, sometimes they just pull out the ligament itself and put it in. Normally when we use ourselves, it's more likely to stay and take place in there. The strongest day after ACL reconstruction is the first day, and with the cadaver, it's more likely to reject the person, and then they'll have to have a further ACL reconstruction.
okay.
And rehab's really important because if you don't rehab it right over time, you can cause them to tear it again.
Okay, so they'll either put material from yourself or from the cadaver, okay? But the point is, you're now seeing, this is ACL reconstruction. These are the plugs, so the tendons, the tendons in here, okay? And you're absolutely right. Rehab's important to strengthen because the only thing that's giving it strength is quads mechanism, all right? So radiographically, this is what it looks like. They can fail. Just because they have surgery doesn't mean they can't have further knee discomfort. The surgical site can fail here, in the middle of where the tendon is, the new tendon is, or the plug can fail, all right? There can be infection, all right? If I was you in your shoes, I'd get the report of the post-surgical report, what was done, so that I can say on this is 2022, 2 years ago, they had a reconstruction, okay, but the patient now has pain. What did they do previously, and what do I have to be aware? If there's gonna be a mess, it's gonna be within the first 4 to 6 weeks, my suspicion, okay? I'm just showing you what it looks like on an AP. We're gonna talk about knee positioning. This is just what it looks like on the x-ray. Can't tell, this is a lumbar spine, this is a vertebral body, this is an artifact, okay? So in your x-ray suite, you can't have any light coming in. Now, it's less of an issue with the digital system. This guy had a conventional x-ray, and he had every computer in his office connected into his darkroom. And you know that you've seen the lights, the parade of lights from the computers, okay? That was causing this artifact on all of his lumbar spine x-rays. It took the better part of 2 weeks to figure out what was going on. I said, you need to make sure underneath the door is covered up with light. He did that, didn't solve the problem. Turned some of these computers off, took an x-ray, and this went away. So artifacts can happen from patients, but they can also happen because of extraneous light, all right? Now, in our room, if you've been in our suite, the lights can be on all the time. The lights don't affect that. That's the beauty of the new digital system. It can pick up things that we weren't able to pick up previously, and there's all these dots, and there's so many of the dots that it can overcome some artifacts, so this is conventional X-ray. These days, the biggest artifact is clothing, rings. And I guess rings are part of clothing. Okay, what else do I have? Body part?
Tib, fib.
Tib fib. Now, there is no marker, so we assume anatomic position, yes?
Yeah.
And an anatomic position, this is?
The left one. Oh, that's the right one.
Which
Unless it's evil.
In anatomic position, where's my fibula?
On the right.
Lateral,
Okay, so which one is this?
right.
That's
Oh my god.
we're looking
Well, if you were
straight at
facing
it.
us, your fibula's on the outside. On the
This is
right.
anatomic position. In anatomic position, where's my fibula?
On the left.
On the left side. This is the left leg. Okay?
Well, the problem is
So then question for the
So if I stand like
I
this,
understand what you're saying.
this is the right fibula, that's correct. But what's our standard?
Anatomic.
Anatomic position.
Yeah,
Give us some
yeah,
flashcards for
I know
that one.
but question, why can't you see the rest of the foot on the MRI then?
Okay, because this is coronal MRI, we're going from front to back.
I completely
Oh.
understand what you're saying.
Gotcha.
Okay?
There's a humoral rotation.
So the point is, if you don't know how they took their X-rays, not everybody does anatomic position.
Right.
Okay, in this case, they failed to mark, okay? Chiropractic office failed to put the marker on. All I'm saying is we're using anatomic position, and in anatomic position, we're saying this is the left leg, okay?
Mhm.
So there's a problem with the distal portion of the left fibula, okay? They had ankle discomfort, that's what it looks like on an MRI. Is there expansion of the bone here? Of the cortex, yes. Is there expansion on your plain film? Yes. This is a little marker that they use. This is exactly where the area of interest is on the MRI. Okay?
Mhm.
What happens to this fibula if it keeps getting bigger and bigger and bigger and bigger?
Fracture.
Fracture. This just pops.
Yep.
Okay? Now, if it gets kicked there with a soccer cleat, it's going to undergo pathologic fracture or traumatic fracture. But if it gets bigger on its own, because the patient, this is just the disease process that they have, this will get bigger, bigger, and bigger, and finally pop. Okay?
Mhm.
Now, at this point, the chiropractic physician could have made a decision. I need an orthopedist. The orthopedist said, I need an MRI. Why did he need the MRI? Is there a difference between this radiolucency where the laser pointer is now and this one in terms of size?
Yep.
Fuzzy says yes. What say you?
What say you?
Is there a difference between what?
So is there a difference between this
Yeah.
and this area?
There's a radiolucency.
I mean, the radiolucency just shows that it's like a hot spot. It's the area.
Well, it's a radiolucency. What I'm asking is this about the same size as what you think you see on the MRI?
Yes.
Okay, it can either be the same, or I'm gonna argue that maybe there's a little bit of inferior extension here, right? That's why the orthopedist needs it. He's gonna clean this out, but he also has to appreciate there's this. If he doesn't clean this out, all right, there's a recurrence rate that happens with incomplete excisions. Now that's their end. I'm just saying, plain film, this is how National Board Part 3 is for you. Plain film, make a decision. And if this is dramatically bigger, that's because the MRI is a more detailed examination, correct?
Correct.
So the multiple choice question here may reflect that. No change in size, a bigger change in size, it shouldn't be smaller, something that is obvious. Okay? They're just saying, what do you see on the MRI? Did I need the MRI? No, I'm gonna make a decision.
Based
If
on-
this patient is a soccer player, you can't play soccer until we get this looked after. I don't want it undergoing pathologic fracture on my watch for my clinic. Does that make sense?
So what would you name that?
That
It doesn't
comes in
matter.
Semester 7, it's condition
Okay.
X,
Okay.
Dr. D disease. Okay?
Yep.
Somebody else had a question?
We were also
We were all
what it was.
wondering what it was.
Oh.
It's got a particular characteristic, it's called an enchondroma. Okay, and enchondromas are typically found in the hand. This is not the hand, so it's atypical, all right? But the point is, you saw this, but it's commanding the cortex. So it depends on how risky you are. Are you risk tolerant or not?
Yeah.
All right, if it's a soccer player, changes everything because he or she can get kicked there. If they're a couch potato, I can wait, I can take this x-ray. If it doesn't change in size, it's slow growing, right? If, on the other hand, between now and Christmas time, it's gotten twice the size this way, that's not good. And at Christmas time, I have to say, I've got an expanding lesion, doc, I need it to be evaluated. Okay?
Yep.
When they hear that, change in size, you're going to the orthopedist the next morning, or later on this afternoon if he can fit you in. Okay? So we can make decisions based on our plain films, but national boards will give us this, and that's why we practice the way we practice. Always imaging. I'm not worried about national boards. I'm concerned about that you make good decisions when you can order the MRI. Okay?
Damn.
Okay, last one, spine. Which part of the spine?
Lateral, sagittal.
And thoracic.
Okay, cervical and thoracic. All right, is there a difference between where the laser pointer is now and this?
Yeah.
Yes,
Decrease.
how so?
Decrease vertebral height.
Decreased height, good. Signal in terms of colorization. Normal signal intensity, this is increased, but so is this increased. So this is paraspinal muscle tearing. Okay, this is what happens when you roll your son's truck 3 times and land wheels down. Okay? So these are compression fractures. Okay? And after my wife got out a week's stay at hospital, you couldn't touch her back. They gave her a brace from mandible down just to below her breast tissue. Okay? And when she was out of that for showering, you could barely touch her. Okay?
So this actually happened.
This is my wife's x-rays.
Damn.
Okay, what else do we have? There's the brace, okay? So back to what's important, okay? Increased signal intensity, paraspinal muscle spasm, okay? The thing I want to add is I saw the neurosurgeon come in and do a consult when she was in, before she went up to her room. A complete neurologic examination. Yes, he didn't have the smelling salts for old cranial nerve 1. No pinwheel, just his hands. Tap, 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 complete. I was impressed, okay? We don't need the techie tools all the time. Yes, they're nice if we have them, but things can be done without them, okay? And so she's in hospital for a week, came home. We took her to, I don't know if you were here when Dr. Michael Hennings was here.
Nope.
Okay, he was a chiropractic neurologist, did some teaching in the anatomy department a couple years back. So he and I know each other. We took my wife to him, 2 1-hour sessions. I don't care whether I know what's going on, I'm watching. She's counting backwards from 100 in units of 4, jumping on a little trampoline. And then he does this chiropractic neurology magic. Okay, 2 1-hour sessions. And all she said, yes, she was remarkably better. Okay, does that make sense? All right, from the time after this, from barely being able to touch her, after about 3 to 4 months, more and more pressure, more and more pressure. This took about the better part of six months. Okay, all right. And because she was in this, I'm the caregiver, so I understand now that whole scenario. Okay, and all she has now is she gets cranky when she gets tired, but I get cranky when I get tired.
Oh
so
boy.
So all that to say, you're going to be surprised what happens in your extended family in terms of disease processes.
Yeah.
My dad died from metastatic disease of the stomach, so gastric to lumbar pelvis. Okay. I told you about my son's finger. Okay, fractured finger. Okay, ka-ching, ka-ching, ka-ching. All right.
That's your son?
Yes.
You
indeed.
made that, Dr. D? Awesome.
And you'll be shocked at how much there is in that extended family. Okay? You have no idea what you're up against. And if I haven't told you before, what's craniosynostosis? You're right, you have to Google it. I had to Google it. The little boy came in with his mom. Okay, he was wearing a hockey helmet. Of course, I have to ask what the hockey helmet's for. Craniosynostosis.
Oh yeah, you told us about that.
Asymmetric. I told you that. Okay? I didn't sign up for that at chiropractic college. Okay? She came in because she thought I did a good job with her neck pain. But he was always on her chest when we did the supine manipulation and work, okay? He had craniosynostosis, and that helmet will make the sutures close so that it's symmetric, okay? Now, the big thing is, while that's happening, is he achieving his normative data points in terms of cerebellars and cerebral development, right? Okay, those markers have to be there. But the cage enclosing, the skull part of it, will fuse nicely. Okay, in the US, they give him a $10,000 helmet that's specially fitted, okay? Sometimes a hockey helmet works just as well. So all that to say, it's like Christmas, you don't know what you're going to get, what patients are gonna walk in, okay?
Mm-hmm.
And I wish I could have saved bilateral sciatic radiation. Dorian's height and weight worked in the oil rigs. What are the oil rigs? Oil patch.
Mm-hmm.
In the middle of nowhere, they drill for oil, okay? This guy came in, he's on 2 weeks vacation or whatever. Bilateral sciatic radiation. Okay, I knew that wasn't good. All right, took an x-ray, he's got a lumbar spondylolytic spondylolisthesis where his L5 vertebral body is anterior and inferior to his sacrum. It's not even in the book. It's off the charts, it's off the Meyerding charts, okay? I said, okay, you're going to a big center, you need to take my x-rays, the x-rays I've taken, and your clinical situation, and you need to be evaluated for disc issues and all kinds of complications. I don't remember signing up for that either. I didn't have a Cox table, okay, but when I have bilateral sciatic radiation, that's out of my realm, okay? That's what I did. So my point to you is, you've got to be suspicious. You've got to figure out what you're going to do clinically. And some of that comes from book knowledge, but some of it comes from Google Scholar. Some of it comes from, well, yeah, Dorian said, I had 2 cases of L6 spondylolytic just last year. What did you do with them? Okay, in other words, spread the bad news around. Okay, the good news you can reserve for the glass of wine at reunions.
Would that affect his height? Like if he was 6 foot, would he like go down to like 5'11" or 5'10"?
Spondylolytic spondylolisthesis.
Yeah.
Not that dramatically.
But like if you came in and did a height exam, I don't know, I feel like I would be like, I'm shorter than usual.
Well, but it's not as dramatic as you think it is. We're not going from 6 foot to 5'8". Okay, would I expect it to go from 6 feet to 5'11" and a half? Sure, that could happen. Okay, because his vertebral body. Okay, but why is he getting sciatic radiation? Because as the vertebral body translates anteriorly, it's squeezing and irritating the hell out of the exiting nerve root. The disc is the problem, but the inflammation around the exiting nerve root is causing all of these issues. If you talk to the neurosurgeon or the orthopedic surgeon, say, what do I do with bilateral sciatica? I think to a person they'd say surgical intervention, not today, but today. Okay. Okay.